I've been getting to know Dr. Weisbart pretty well. He's our National Board Secretary and the Missouri Chapter Chair for the Physicians for National Health Program, a nonpartisan nonprofit organization that supports single-payer national health insurance. He is a retired family medicine physician who's practiced for over 20 years in Rush Medical Center in Chicago before he moved to St. Louis, where he became the Chief Medical Officer of Express Scripts. During that time, he also volunteered as an assistant professor in clinical medicine at Washington University in St. Louis. And he also served as the president for the Consumer Councils of Missouri. Thank you very much for coming again, Dr. Weisbart. We look forward to a little more about Medicare privatization.
Well, thanks. So I have a lot to talk about in a small amount of time. So I'm going to focus specifically on the issues of Medicare Advantage as sort of the poster child for privatization. And there's quite a bit of important information about this. And then there's even more important information about this that does not yet exist. Most of the things that we would want to know about the impact of privatization and Medicare Advantage on equity, it's not really out there just yet. So instead, there's a lot of other things that are out there, and we'll show you kind of what I mean by all that. But get some slides as always, and there you go. Pretty sure you can see that. So we're going to talk about how, and I'm framing this as the inequities, even though the Medicare Advantage corporations frame it as themselves as a solution to equity, and we'll unpack both sides of that. But to start, maybe I thought you would hear about, maybe because you're kind of holed up in on Zoom, you don't get to look at the news as much. So I thought maybe I would digress for not really a digression for a minute about some breaking news. So I don't know if you've read this. There's a report in the New York Times, a milestone in finding better ways to improve well-being, a financial incentive to keep subscribers healthy, shift the emphasis of medical care to the prevention of illness, a model that's been adequately tested where many potential subscribers would be medically underprivileged. Anybody know what this is? You hear about this breakthrough? It's the HMO Act of 1973. Woohoo! So you were probably trying to think of what current program, and you thought this would be about, because there are many that would have been described in this obviously grossly misleading way. And the good news is that this isn't new. This has been going on for a while. So I thought it's worth a moment to set the landscape of where Medicare Advantage kind of fits in to things. So have you seen, I don't think you've seen this chart before. No, yes, no, you haven't. Okay. So this is kind of wonky, but let me unpack it for you. This is 51 years of data from 30 comparable countries. And it's comparing life expectancy versus health expenditure in US dollars per person, of course. So there's each one of those different colored lines is a different country. Each one of those colored lines is a different country. And you can see a couple of important things right off the top. Life expectancy, at least up until the pandemic, was kind of gradually, steadily plotting its way to longer and longer. And likewise, you would see that the expense has been gradually going up and up, but we're getting longer lives perhaps. So which one of those colored lines, do you think the teal one or the blue one, which one of those colored lines do you think is the United States? Well, it's of course a trick question, because there we are. There we are. So some things to notice on this chart. The first is back in 1970, we were normal. If you look in there, in 1970, we were, roughly more or less in the middle of the pack. And now we're obviously not. So now we have life expectancies that are, 4 or 5 years cut short from what the rest of the world is. And we spend roughly double what the rest of the world spends per person. So, not much to be real proud of there about that. What's the difference? What's going on? Well, all of those other countries have some form, some flavor of national health insurance. And I know you're studying that in this course. And you probably already know that every single one of those is different. None of them are duplicates, and there's all sorts of detail around that I believe you'll be unpacking during the course. We're the only one of these countries that does not have, guaranteed national, universal, high quality, comprehensive healthcare. We don't have that. But we haven't been sitting idly by. We've been doing all of these other things that we've been trying, each of which with the promise of improving health outcomes and lowering cost. And yet the curve has not bent. Each one of these things has as its core model something that's absent from the other countries in the green circle, and that is that each one of these models in red introduces profiteering and privatization, some fiscal intermediary, some corporation that is attempting to make profit off of it. We're the only country that has that as our test it and test it and test it again. So we're going to talk about Medicare Advantage right in the middle of the chart, and it's I think a pretty good example of what's going on. So PNHP docs, we've been going to Congress and talking about how things like Medicare Advantage have been hurting our patients, not to mention costing a lot, but we've been trying to persuade Congress that Medicare Advantage has been hurting people. But we're not the only ones talking to Congress about that, because indeed, AHIP, formerly known as America's Health Insurance Programs, I think, it's the lobbying group for the insurance industry and certainly for Medicare Advantage. And AHIP has been repeatedly telling members of Congress that Medicare Advantage is the solution to the great problems of equity in our country. And if you listen to those wacky doctors, you'll be attacking the program that is most positioned to improve inequities. So don't do that. They defend themselves by that. So, what's really going on here? How is it that AHIP can make that claim? And it's an important claim that they make because every time that we talk to people in Congress or their staff, they usually agree with what we say about the overpayments, the subsidies, and about the harm. Even they usually agree with that, but they keep coming back to this. If that's all true, we still can't do much about it because this is addressing inequity, and that's a really important and worthwhile goal, a goal that we of course share. So how do they get away with saying that? How does the insurance industry make that claim? A claim that I'll explain in a moment, and then I will dispute for the next 15 minutes. How do they make that claim? Well, they make it based on some information. Before I get there, here's why I would dispute that. So our study that I think you hopefully have seen by now shows that Medicare Advantage firms cause harm in all sorts of ways, and I'm not going to unpack each one of these, but I think you're familiar with that, about how the insurance industry causes unaffordable care and creates barriers and burdens and all of this. So our report unpacks this in detail, and I will not. I will just show you the data points that I think are particularly relevant to the concerns about equity. So they do that. So AHIP, on the other hand, says the opposite. AHIP makes the claim that they're the vital source of coverage. Direct quote: Medicare Advantage is a vital source of coverage for low-income and diverse populations. So they say that based on two data points, as far as I can tell. Here's the first: that if you look at overall, and their current report on their website, which is dated January 2024. It's as current as you can get. I looked today again. Is based on 2021 data, so the numbers are different from what we know they are today. But that's not really a qualitative difference from their argument. But if you're looking at the numbers, going, that's not right. You're right, but it's 3 years. The data is 3 years old, so be of good cheer about that. Give them a break for that. So overall, Medicare, the percentage of people in Medicare Advantage in 2021 was 44%, but among African Americans and Hispanics, the percentage of people in Medicare Advantage, percentage of Medicare members who are in Medicare Advantage is significantly higher. So this is part of their argument that they are a vital source of coverage for diverse populations. This is where Black and Hispanic and Latino, Latinx folks are going for their Medicare product. And likewise, if you look specifically at low-income people, that people of low income are more inclined to be in Medicare Advantage than in traditional Medicare. So if you did something to disrupt Medicare Advantage, you would be potentially harming the people most in need of a good healthcare solution, the one that they have chosen in the free market. That's all hooey. How is it that Medicare Advantage plans can attract these populations? Are they indeed the solution? And how good are these plans? So let's look at a couple of data points. And I'm picking this easy one first. I'm picking dental first because, as you know from the TV ads, one of the things that Medicare Advantage companies promise people is access to dental care. You know, that's good. People desperately want access to dental care more than they want access to you guys. They want access to dental care. So it turns out that people in Medicare Advantage are less likely to be able to access dental care because of cost than are people in traditional Medicare. Now that's a somewhat confounded piece of data because it's not corrected for income and wealth. And so we know we've shown you that people of low income are more likely to be in Medicare Advantage. So I'm sure that confounds that quite a bit. But it's still worth looking at because the fact remains that they're promoting themselves, MA plans are promoting themselves as offering a robust dental benefit, and yet 30% of people in MA say that they can't access dental care because of cost. So hard to see that that's really what they're promising people. And indeed, writ larger than just dentistry, people in MA are more likely to have cost-related problems accessing care. So overall, if you look at the whole population, people in Medicare Advantage versus people in traditional Medicare with Medigap, that's what this study looked at. It was people in traditional Medicare with Medigap. That people in Medicare Advantage have much more trouble with problems accessing care. And remember, the benchmark for Medicare Advantage, the way Medicare Advantage companies are paid, is ramped up to include the actuarial equivalent of Medigap. So the Medicare, remember that I told you that the benchmarks for Medicare Advantage are based on the traditional Medicare book of business, 90% of whom have Medigap. So Medicare Advantage companies are paid by the federal government as if they provide a Medigap equivalent, and yet here's proof that that's really not the case, that people in Medicare Advantage have more trouble accessing care because of cost. The ratio is about the same in whites, but still pretty impressive. Hispanics, it's higher, and then among Black Americans, this is just, and this is the solution to equity. This is the solution to equity. It's really hard for me to see that when you sort of compared some of the bars to each other. And then if you look at people in Medicare Advantage who are have compromised health, who have fair or poor health, the problems with accessing care are even more striking. So people in traditional Medicare, in fair or poor health, roughly the same as people as for blacks and whites, whereas in Medicare Advantage, it's a pretty profound disparity here. Again, hard to see how this is the solution to equity with data like that. And one last of these kinds of data points before I show you something even more disturbing. In these data points, if you look at people in their final year of life, if you look the year before the final year of life, less than 2% of people in Medicare Advantage leave and go back to traditional Medicare, which, as you know, is hard to do because you don't have guaranteed issue of the Medigap. We won't unpack that again, but 1.7% of people in Medicare Advantage every year tend to go back into traditional Medicare until the last year of life, when it's almost 5%, 3 times as big, roughly, something like that. I don't know, you do the math. It's a lot bigger. And the reason for that, why is this such a phenomenon the last year of life? The reason, among other reasons, is limitations accessing specialty care under Medicare Advantage. So when you're younger and healthier in Medicare, you can kind of put up with this. It's not what you want, maybe, but it's not as dire and as important to you. But in the last year of life, it becomes a big deal, and people do actually try to get out, or do get out. And here, I think, is the most disturbing data point about this. If you look at cancer patients in Medicare Advantage, and you look at here's 5 cancers that were in this study from last year. It turns out that people in Medicare Advantage wait longer to get into definitive treatment for their cancer. The time between diagnosis and treatment is longer. And, for some cancers, a few week delay is a change of stage and a change of mortality rate. So they wait longer to get into definitive treatment and we know why. I mean, we know why they wait longer, because the Medicare Advantage companies require their approval to do most things that are expensive. I tried to get a CT scan for my wife that her doctor ordered, and I called radiology and I said my wife needs a CT scan, and they said, well, what kind of insurance does she have? And I told them, traditional Medicare and Medigap, and they said, what time tomorrow do you want to come in? And we got her in the next day. And then after I scheduled that, locked that in, I said, so, why did you ask me that? And they said, because if you had Medicare Advantage, we would have told you we'll call you back in a week because we have to go through the approval process, and that takes at least a week. And that's what's happening to cancer patients. Virtually all chemotherapy and elective hospitalizations require prior approval in Medicare Advantage and not in traditional Medicare. That doesn't happen there. But virtually everybody in Medicare Advantage has to get prior approval for things like cancer care. And as we know, that can kill you. And indeed, they don't get to go to the preferred cancer centers. So if you look at people, whether they can get into a National Cancer Institute designated center of excellence, people in Medicare Advantage are far less likely. Now, if you have appendicitis, if you got a broken ulna, probably your local community physician does a lot of that kind of work, and is probably incredibly competent and skilled and able to do that work. But if you have cancer, if you need a Whipple's procedure, if you have something less common that needs something really technically difficult to do, I'm sorry, I want to find the best place in the country and go to it for that. And indeed, people in traditional Medicare usually can, if they choose to. They don't all choose to, obviously, but people in Medicare Advantage typically can't. Typically, the centers of excellence are not even in network. So, is this important? We talked about they get treated later. They don't get to see the centers of excellence. Is that important? Yes, as it turns out. The 30-day postoperative mortality rate for people in Medicare Advantage is significantly higher for many cancers than it is for people in traditional Medicare. So they're delaying the care, and they're not going to the centers of excellence. And as I suggest, as a consequence of those two things, they die more. So when we hear from the insurance industry that Medicare Advantage is a vital source of coverage for low income and diverse populations, the numbers they quote are, I believe, CMS driven and are true. But the reason that the numbers are like that is because people that have the financial resources to buy Medigap don't put up with the inferior insurance that is Medicare Advantage. It's really, and some ME companies, people in them get great care and get great results. I'm not saying everybody in there, but it is an inferior insurance product that most financial advisors to people of high wealth tell people, don't do that. Stay with traditional Medicare. And indeed, people that have the means don't go into Medicare Advantage. So that's not the solution to equity. That's part of the problem of equity. It makes me furious when we hear that they're the solution, because it's the exact opposite. That's frankly a weak set of arguments. I mean, those are arguments that are compelling to me, but they're not as comprehensive and robust and linear and cause and effect as I would like to see data for. And I think what I just showed you is the best data that there is evaluating this. But we have in PNHP, we've determined that is going to be our next. We've done 2 reports, overpayments and harms, and we want to draw the connection between overpayments, harms, and equity. So we're just sort of in the conceptualizing phase of that, but that's where we're going with it.